Good afternoon. I am Jessica Carroll, the implementation lead for Measure 110, and I will be assisting Blue Valentine with facilitation for today's meeting. The Oversight and Accountability Council welcomes and encourages community input. Members of the public are invited to submit public comments or get on our interested parties email list by emailing oha.measure110@dhoha.state.or.us. That email address and more information about the council can be found on the Measure 110 OAC website. For more information or support with community engagement, please contact me, Jessica Carroll. My email will be dropped in the chat. OAC members have asked that OHA and other staff who are present in the meeting space introduce themselves in the chat. Please share your role with the agency, and if you are a subject matter expert, your area of expertise. And while OHA staff are introducing themselves in the chat, I'm going to throw it over to Walter for a roll, please.
Yeah, thanks, Jessica. Good afternoon, everyone. And I'm going to go from the top, just say here, once I call your name, please. Amy, is Amy here?
My phone's going off. I'm here.
Hey, all right. Blue?
Here.
Okay. Carlos?
Here.
Okay. Caroline?
Here.
All right. Dharma? Okay. Aowen? Okay. Henry? Okay. Hubert?
Here.
Okay. Karen?
Here.
Okay. Keisha? Keisha, are you there? Okay, I'll come back to Keisha. All right, Lana? All right, Leticia?
Here.
All right. Melinda?
Here.
All right. Morgan? Nicole? Okay. Onisha?
Here.
Hey, thank you. Ron?
Here.
All right. And Sabrina? Okay. And Zeb?
Here.
All right. I'm going to check the chat real quick. Maybe Keisha said. All right. Keisha, are you here? I see her. Okay. All right. Well, maybe she'll check in when she gets an opportunity, but I'll turn it back over to you. Right now, we do not have quorum. Jessica, oh, Steve, excuse me. Let me finish my list. I'm sorry. Steve, hi, Steve.
I'm here, Walter.
All right.
Hey, good to see you.
Yep. Reginald. All right. Okay. And I did hear you.
Dr.
Thanks.
Richardson.
Okay. And I heard Keisha. Thanks, Keisha. All right. Turn it back over to you.
So we're at
Jessica.
we're at 13.
We're at 13. Yep.
Thank you.
I have reached out to Sabrina will be joining us soon, and Aowen had emailed that she will just be a little late. So
Okay.
we should hopefully meet that. And if not, we'll do some outreach.
Okay. Thank you.
Okay,
So-
awesome. Oh, all right. Thanks, Jessica. So today on the agenda, we have some OHA updates with Jessica, and we do have a county that we will be voting on for the grant agreement approvals. And we also are going to have a behavioral health investment update after that. And it should still hopefully be a little bit shorter meeting than normal. So maybe everyone can go out and get some sunshine. So I'm going to turn it back over to Jessica for the OHA updates.
Thank you, Blue. And if I could get the update slides, please. Thank you. All right, so these are your burn updates. Next slide, please. All right, so, okay, there we go. It's okay, sometimes it's, yeah. All right, so the applications for the following counties have been approved. You can see that we've put the grant agreements that have already been sent out and signed in green, and the contracts that have been initiated are in yellow, meaning they are out for signature. Next slide, please. And these counties are still in negotiations. Next slide. All right, so applicant meetings are moving along. Meetings with approved applicants continue. And this is the information for the welcome meetings that are provided to each individual organization. So they get the orientation of Measure 110, grant agreement template, model MOU, facilitation technical support assistance, and their EFT form for them to fill out to make sure that they have that set up. And those are all presented at the welcome meeting. Next slide. All right, so these are the negotiations that have already happened. These are the follow-up and negotiations do continue. So you can see they started, they are continuing through. Next slide. We only have a few upcoming meetings for, these are welcome meetings. Negotiating meetings continue, and those are dependent on the situation, the organizations, the county in which those are happening. The welcome meetings, all welcome meetings have happened except for Jackson, Multnomah, and the 9 tribes in NARA, and those are being scheduled and coordinated. Again, there was a survey created for the Multnomah applicants to help inform that negotiation process, because it is obviously a very large task considering the amount of organizations. And I believe that is our last slide. Thank you. Are there any questions? Ron.
I didn't have a question.
Oh, sorry, you came off mute. I thought you were going to ask me a question. Never
No, I was
mind.
just gonna note that I saw Henry and Sabrina come on, so we should be at 15.
Yay.
Yay. Yep. And I think I saw Nicole just come in too as well. So I think, yep.
So I would recommend we move to the approving the grant agreement and then take the rest of the agenda from there.
I do see Sabrina with a hand up.
Yes, I did have a question around the negotiation process. Do we know how long that we foresee that playing out for these counties across the state? Or is that even feasible to try to have a timeline?
Sabrina, Steve, I could take that question. I think it's still really difficult to know. What you all have done is approved half of the county regions now. And those were the county regions that were, regardless of size, more straightforward. There's still maybe a few that are more straightforward, but as we get into these, each is unique. And sometimes there's complications that we need to work through. So I'm, Dawn would kick me under the table if I gave you a date, but it's likely to be, more than 6 weeks. But it really is very specific on, what does it take to help the counties, all the entities within that county region to reach agreement on the budget and the MOUs. So we'll have more. I think we'll have a better beat on that in the next few weeks.
Say, Steve, this is Hubert. Can you hear me?
Hey, Hubert, absolutely.
How you doing, Steve? So,
hey, I'm doing good.
That's good. So I'm curious about how tight would that window be from the time we finish negotiating for all these contracts to when we got to start the process all over again? Will we have like a 30-day gap before we start the process over again, or a 60-day gap? That's where I'm kind of trying to see where we'll be in this process.
That's a really good question, Hubert, and something that's already on our mind. We think that process needs to start really immediately, with maybe beginning process of kind of looking backwards for a couple of weeks. What are the lessons learned, sometimes painful by OHA, sometimes by the council? What kinds of things would we want to do differently? I think, in my view, that ought to start the process. But I think, you all remember what it takes to really design what is it going to look like this time, what will be the priorities, all of that just takes time to craft all of it. So my view, that should start really quickly, but I think our plan is to bring proposal to the tri-chairs fairly quickly. When we're trying to walk and chew bubblegum at the same time as we try to wrap up all of these negotiations and get money out the door as quickly as possible, but not neglecting planning for the future. Planning for the future, by the way, also includes those organizations that you've now funded, because some of those have now been funded for a month or more. So there's a lot of technical assistance and support that needs to take place. So that's also happening in background.
Thank you.
You're welcome.
Any other questions? Okay, so then I am gonna turn it over to Steve for the grant agreement approvals.
I did have a question, Blue.
Awesome.
I apologize. I could not come off of mute fast enough and I could not raise my hand.
Okay.
I have one last question. Is there anything, and it kind of sounds redundant, but I'm also really concerned, like if it's going to take 6 more weeks to get some of these counties going, then what is that going to be the time frame for actually getting the funding out the door? And so I was just this kind of rhetorical question, but I was wondering if there's anything that we can do to help these counties along, or OHA can do to be like more of a presence to help them get the contracts kind of tied up, so that way we can actually get the ball moving. And I don't want to monopolize the time because I know that we have a vote. So if somebody could possibly address me in an email or a text or a phone call, I'd really appreciate it.
Sabrina, this is Steve. Another really good question. I'll give you a brief answer, but happy to follow up. So our hands are tied in terms of getting money out the door until we have a county region that's within budget and in which all of the partners are actually forming a resource network together and signing those MOUs. Once we have agreement from you folks, approval for the region, and the MOUs are signed, that process has been moving extraordinarily quickly. We have said 20 days, but we're beating that. Now, of course, we had a surge last week with 8 county regions being approved, including Marion and Washington. So I'm not sure if that's going to slow us down a little bit just by the sheer numbers of approvals for that. But that's not, getting money out the door hasn't been the barrier. It's been getting the agreements among the partners and getting the budgets negotiated. So we're doing that very deliberately. There's county regions that we've been, you can see we've met with all the county regions except 2 now. And so we've been going on these negotiations for a bit, and we'll be wrapping them up. I think we only have 1 this week, but there's a bunch in the hopper, and hoping that we can bring a good 5 next week as we move this along. Is that helpful?
Yeah, I had just one last question, Steve. So I was wondering, are you guys proposing each organization with budget cuts? Are you overall telling each county, this is the funding that you guys get, now figure it out? Or are you helping them say, well, this is what the OAC agreed for your organization, and so this is how we're going to deal with it? Are you guys doing that for per organization or per county?
Yeah, so the thing that we're very clear about not doing is pitting organizations against each other. And we see that very clearly up front. We ask them if there's anything that we're doing that looks like that, let us know, because it's not our intention. And the reason for that is really simple, is that you all want these entities to work in partnership with each other in collaboration. And if we set up a process in which they end up feeling like they have to fight against each other to start with, they're just all getting off on the wrong foot. And so we don't want to do anything or have a perception that looks anything like that. We've worked really hard in that regard, and I think we've been successful in helping to avoid that. Not that there's not going to be some tension. There is, and there will be, but we've been working really hard to avoid that. The way the negotiations have been playing out does vary county region by county region, and in some cases, the county regions already have their own ideas about how to get there from here. In some cases, it's pretty clear to us is because they're so far over, the only way to get there from here is to cut a piece of the infrastructure that they proposed. So, you know, that is a more straightforward path. We're now getting into some complicated counties where every provider may need to take a cut. But we're having open and focused dialogues, you know, with all these county regions, and we're trying to be responsive to the dynamics within each one, and that just takes a little bit. Is that helpful?
It is very helpful, Steve, because I was just wondering how that was going to play out with the subcommittees coming up with their suggestions and saying, we're going to fund this part, but not that part. So I could see where that would shave off of the budget per each county. But thank you for addressing that, Steve. I thank you.
Yep. You're welcome. And I think I said this last week, but Jessica and Sydney and that team will go back and read all the notes that were taken very carefully. They'll go back and actually watch the deliberations and with fresh eyes to make sure that we capture your intent really clearly. And that's the most delicate and difficult when you've partially funded a program, and then sometimes we have to work with the provider to kind of figure out what does that actually mean, because their budgets weren't, you know, chunked off in the same way that that the services were. So it takes a little bit of work to get down to what does that actually look like, and how does that actually work in practice. But we're very intentional about that process. We try to do it very carefully.
I see Ron has a hand up.
Right, thank you for that. Great question, Sabrina. Thank you, Steve. Just on that point you were just making around partially funded organizations, and you spoke a little bit to this last week, but I'm not sure it really landed in my head in a solid way, which was for organizations where the subcommittee decided to partially fund them in counties where there's additional funds or a surplus or is it being considered that one or more or some organizations would now receive full funding, or is it just what we talked about last week, which is that a housing provider or set of housing providers would receive additional funding to provide housing, and failing that, the balance would be distributed percentage-wise based on the allocation to the county or the county percentage of their budget as it relates to the allocation?
Yeah, I understand that question, Ron. So far, we have not. So maybe I'm trying to say this as clearly as possible. So far, we've only funded organizations that the council approved and areas in which the council has approved. So if ABC agency was funded for everything but harm reduction, we have not gone back and negotiated that same organization to provide harm reduction, because we're taking your lead as a council that you didn't believe that this was an organization that provided harm reduction along the values of the council. So we may be coming up against county regions where I think what you're describing, Ron, is, for instance, a housing provider that was only partially funded, which means that the council had concerns about them. Would we then fully fund that same housing organization? And the answer to that is, I don't know yet, because I think we may well run into that situation, and I think we'll need to be really thoughtful about what does that mean and how do we apply it. What I will commit to you all is that if we end up making a recommendation like that, you will not be surprised by that. It won't be hidden. It will be something that we say, you partially funded ABC organization for housing. Here were the concerns that we heard on tape and had in the notes. And if you would like to add additional housing, this is what it would look like. And then you, as a council, could decide whether you want to go down that road or not. So
thank you, Steve. Appreciate
ultimately, yep, we see these decisions as being solely yours. You have the authority. Our job is to negotiate on your behalf and to bring forward recommendations along with sort of the fine print about what our thinking was, so that you have all the options and information available to make sound sound decisions.
Thank you.
You're welcome.
Karen?
Hi there, everybody. On the housing, I've been thinking about this a lot this week, the conversation we had last week, or I guess it was Friday. There are a lot of different kinds of housing, and it seems like, I don't know if we're thinking too much inside a box, but you know, when we think about this referral pathway and people having outreach services and engagement services that are happening both through the burns as well as through the Medicaid SUD waiver, there needs to be some places where people can go quickly. You know, we've talked a lot in this council about low barrier treatment and low barrier services. And, you know, I would just strongly encourage us to think about housing in a little bit of a more broad context, especially for people who do need a low barrier place to go. Like I'm thinking about a respite, some kind of a respite place. Otherwise, I'm not sure where people are gonna go. You know, if we have, you know, ideally we have a lot of people who want to go somewhere, who want to engage in something. And so I'm just hoping that we can meet people where they are and not try to force them into a box or whatever boxes we're saying have to exist around housing.
Yeah, Karen, I can respond to that. So the council actually authorized 6 types of housing, including a number of forms of low barrier housing. When we're in negotiation with county regions, it's the low barrier housing that we're emphasizing to help ensure that that particular type of housing where people have access to housing regardless of whether they're using drugs or not, and that they don't lose their housing regardless of whether they're using drugs or not, so that we believe acting on the council's behalf. But I see Keisha's note in the chat, Blue, that not everyone can stay for the full time. So I know there's some urgency in getting a vote. Would you like to move ahead with that?
Yes, please, let's do that. Thank you.
Okay, thank you.
Sydney, if we could get the county slide, thank you.
Thanks, Sydney. So Wallowa is a county region that's coming forward today, and I really appreciate the folks in that county region for having some fast and effective last-minute negotiations to get this across. As I mentioned, we have a bunch of county regions that are working on it. We thought we might have a couple more today, but we're looking forward to those being ready next week. Next slide, please. So there were 2 providers in this county region, Boulder Care, you've seen before, and the Wallowa Valley Center for Wellness, who is also the community mental health program in that county region. So able to cover, having a physical presence and able to cover all the bases there. Next slide. In the negotiation between, and this slide looks almost identical to the one prior, but you'll notice that Boulder Care has stepped away from the screening component. It's not because they can't, but because in their discussions with Wallowa Valley Center for Wellness, there was a preference for having those screenings done in person. So they stepped away from that care component, but will deliver options or choice for the remaining elements. Next slide. As you can see, well over budget, as a number of these, especially in the rural frontier county areas, have, and a component of that, as you might imagine, is a needed infrastructure. So that was the budgeting challenges to get down to that threshold 750. Next slide, please. This is a question that you've all asked in other regions. Can Boulder Care provide technology? And their consistent answer, as here, has been yes. They're planning on that. Next slide. And then here's the budget profile here. So Boulder Care has accepted the same budget level as it has in the other small county regions in which it's been, which is that 40,000 level. So that ought to look familiar with the Center for Wellness having the remainder of that budget. Boulder Care actually increased their budget from 26,000 roughly, or 27,000 to 40, keeping in mind that when they proposed across the state, there were over $8 million to cover all the county regions. There was efficiencies of scale in all of those. And so in the process of working out the details of their commitment to this county region and reducing their economies of scale because they were not approved in all the counties in which they provided services, that was the number that they reached, which is the same negotiated number that they reached in other counties you will call, like Wheeler, Gillum, Grant. Wallowa Center was the one who reduced by almost $2 million in 3 areas. One of those was staffing, reduced transition housing manager, medication assisted treatment, nursing staff, 2 peer supports, 2 crisis workers. They downsized $500,000 in supplies and reductions in travel, staff, technology, childcare, gas, utilities, that kind of thing. And then the big chunk was in our capital construction. They had planned to purchase a house if budget allowed it, and to remodel that house to build out their housing options. Regardless, the center reports their ability to provide robust services in the county region within that budget and in partnership with Boulder Care. And I think that's it. Happy to take questions. And if there are no questions, happy to, oh, I see Henry.
Hi, Steve. Thanks for the presentation. Appreciate it. Just curious about the Boulder Care, when they're providing SUD treatment, is that, I'm a little unfamiliar with the agency. My understanding was that they are primarily virtual. Do they have, do they have established treatment providers in Oregon?
They do, Henry, good question. And they're exclusively virtual here in Oregon. And the treatment that they provide access to nursing and doctors who can support medication assisted treatment. That's their the treatment modality that they support.
So they don't have any CADC folks or peer support folks that are certified in Oregon?
They do. They have peer support specialists and CADC, but in terms of the sort of the active treatment component, that's their primary.
And they are
So
certified in CADC ones and certified in Oregon to provide that SUD treatment.
I have to confirm that, Henry. I can.
Yeah, that would be my concern, is I want to make sure that we're providing certified folks in the state of Oregon to give those services. And then the other, just the budgetary issue that I see is, I noticed the line item of reducing 2 crisis workers for that area. And having been a crisis worker, I can say, giving Boulder Care $40,000, that's the salary of a crisis worker. So, I want to make sure that we're, as a committee or a council, serving the whole spectrum of need. And oftentimes the folks that are most in need or have the most acute symptoms are often the least served. So that's my only concern, is I want to make sure that we're providing services for folks who are in crisis, especially because there's such a high correlation between substance use disorder and suicide. Thank you.
Yeah, thank you, Henry. Points well made. As we go into these negotiations, we're working hard because the council approved both providers, is that we ensure that there's a viable budget for each. So that's how we walked into this negotiation along with the others. Ron?
Right, just kind of along the same line as Henry. I was more concerned about the reduction of 2 peers and looking at their budget and saying, well, if there are peers that are virtual under Boulder Care, and I'm assuming there are peers remaining for Wallowa Health Services Health Center, Wallowa Wellness Center, I'm assuming that there's still peers in town, in the county, in person. Is that correct, or? You muted yourself.
You're on
Chief.
mute, Steve.
I mean, I don't want to overestimate or underestimate the value of in-person peers on the ground, being able to do outreach and be able to do that warm handoff that becomes like the personal connection on the ground in the county. It's essential in a burn service.
Yeah, Ron, I couldn't agree more. And I'm sorry, I was just trying to navigate to the notes that I had on that county region. So I think let me see if I can grab that quick. Is it showed the staffing that remained after those cuts. Bear with me for just a second. Sorry, I was multitasking and not very well. All right, so what remains is 144,000 in housing vouchers, 2 full-time staff for their drop-in center, a manager, administrator. They said other full-time staff will be leveraged from the broader organization. As I said, as I tried to say when I was on mute, the Center for Wellness is a very robust behavioral health provider in that county. They have a minivan for their peer support harm reduction so they can do mobile outreach. They have contingency management, and then they have a provision for food and community outreach within that. Is that helpful?
Almost. I was listening for the words peer wellness, addiction peer wellness specialist, or addiction peer support specialist. So it's still a question mark. But outreach, assuming those are peers doing outreach, certified peers, recovery peers, certified recovery, I'm assuming that, but I don't know.
Ron? They have Wallowa Center for Wellness, Wallowa Valley Center for Wellness has 3 peers that currently work there. They wanted to add peers, but with the reduction in the budget, they had to, they had to squeeze something out. So that was reduced.
Okay, thank you. So they have peers. That was what I was after. Thank you, Karen.
Yeah.
I didn't see in the chat, Melissa had something about the CADC. If you wanted to jump in, Melissa, real quick.
Hi, thanks everyone. I'm Melissa. I work at HSD in Licensing and Certification Unit, and I heard Henry have a question a little bit earlier about CADC. Henry, do you want to restate the question real quick so I just don't talk and talk and talk? I know our time is limited.
Yeah, I just had a concern because I was under the impression that Boulder Care did not have any staff that are going to be providing in-person services. I wanted to make certain that if, one of the things that they said they're going to provide is substance use disorder treatment. So I wanted to be certain that they had CADC folks that are providing that are certified in the state of Oregon.
Yeah.
As opposed to like somewhere outside of the state and not certified.
I love that question because that's the work that I do, is work with programs to make sure they're certified when they need to be. I actually recently had an opportunity to speak with a legal representative for Boulder Care just a few weeks ago. And they clarified that now they were talking about the Boulder Care location in Multnomah County. So I don't know if when our conversation actually has the scope of what we're talking about now, but they said that they didn't have anyone that was unlicensed that would be providing that substance abuse treatment service, that they were strictly a medical Suboxone clinic. And so maybe things have changed since then. Maybe things are different in this other county that we're talking about right now. CADCs would be the people that we're looking at to provide substance use disorder treatment services. But those also could be rendered by licensed professionals that hold additional specialty training and education in SUD treatment. So if
Yeah.
Boulder Care is given money to provide SUD treatment services, I would hope that they would be routed to my unit at HSD to make sure that they go through the proper certification channels to have that staff.
Yeah, I've worked for different agencies doing clinical supervision, and I think it's something like 60 hours of continued care for a licensed professional to provide the ASAM assessment. So that's all I'm concerned about, is making sure that those folks are licensed or certified and in the state.
Yeah, and not just the individuals, but the agencies themselves need to be certified by HSD to have those individual providers. Thank you.
So what I'm taking away from this discussion is something that we would require regardless as the health agency, is to ensure that providers who are providing care, whether virtually or in person, are working within their licensing and credentials to be able to be eligible to provide that service. And my homework is to go back and ensure that Boulder Care has staff who are properly credentialed, and the agency is properly credentialed for the services that they're offering and that you have approved for working in Oregon. So I'll bring that answer back next week. In the meantime, one way to frame it is either to send this back to resolve the question, or to approve it subject to a change to confirm that Boulder Care is eligible to provide the services it has offered and you have approved.
Any other questions? Looks are good. Okay. Then I think we're ready for a vote, right? Maybe?
Yep.
All
I
right,
think
so I'll hand it over to Walter in that case.
Oh, somebody's got to make the motion.
Oh, sorry.
No worries.
I'd like to make a motion to approve the contracts for Wallowa County. That good?
I'll second the motion to approve Wallowa County.
Is that, I'm sorry,
Thank you,
is that subject to the confirmation of appropriate licensure?
Well, moving into discussion, Ron, I think because the council has already approved multiple counties with Boulder Care as a provider, I think what I'm suggesting is we go back and review all of those the same way. And then I think if they're ineligible to provide the service, then we may simply become ineligible. And then all of the impacted county regions would be in play, including this one. So I think, and that would be true regardless of all the other providers that you have approved. If they're ineligible to provide that service, regardless, once they become ineligible, then the contract is pulled.
Okay. Thank you.
You're welcome.
Okay. Any more
discussion?
Mm-hmm. Okay. All right. Let's take it from the top. All right. Amy, how do you vote?
Yes.
Can you restate the motion? Sorry.
Blue, would you like to restate the motion?
Oh, I will try. There's a motion to approve the contracts or the grants for Wallowa. Can you say it again, Amy? Wallowa County. Thank you.
All right. Amy, how do you vote?
Yes.
All right. Blue?
Yes.
All right. Carlos?
Yes.
Okay. Caroline?
Yes.
Okay. Dharma. Aylwin, how do you vote?
Yes.
All right. Henry?
Yes.
Okay. Hubert?
Yes.
All right. Karen?
Yeah, I'm going to state that the director of this program is on my board, but there is not an actual conflict, so I'm voting yes.
Okay. Thanks, Karen. Keisha?
Yes.
All right. Lana? Leticia?
I abstain due to conflict or possible conflict of interest.
Gotcha. Duly noted. Thank you, Leticia. Melinda?
Yes.
Okay. Morgan? Not here. Nicole?
Yes.
Okay. Onisha?
Yes.
All right. Ron?
Yes.
Okay. Sabrina?
Yes.
All right. And Zeb?
Yes.
All right. And that passes with 15 and 1 abstention. And I'll turn it back to you, Blue.
Awesome. Thank you, everybody that was able to stick around and vote and make quorum. And now we're going to have some updates on the behavioral health investment from Steve.
Thanks, Blue, and congratulations. We're now over the halfway point in the county region, so making really good progress. Thank you. So I think Jessica or Sydney have the PowerPoint. Yeah, thank you. So I'm going to start this off, but I'm going to turn it over to my colleague, Rusha Grimstead, in a little bit, related to 988 and our crisis system. But there's been questions along the way, both from you all and in negotiation with the county regions about a variety of investments and projects that were funded both in the 2021 and 22 cycles. So lots to cover. I'm going to keep this really high level, but please slow me down. If there's questions, I won't be able to see hands, so I'll need somebody to shout that out.
Yeah, Steve, before you really get into this, before you really launch into this, I had a question that's not related to probably this presentation, but I was trying to wedge it in. But it's related to the access to care grants. And it's about the extensions. My understanding is providers are getting the extensions, but my understanding is the extensions, the funding has to be spent by September. And I'm wondering if that's for all providers, or is that on a case-by-case basis, and is that true?
Don't know, because I can't see my screen at the moment, whether John Collins is on, but I'll tell you my understanding, and we can fact check that for you. So first and foremost, these are access to care grants for prior grantees. And what we discovered along the way is some grantees chose not to be funded in the second funding round that we had in January. And so those were the ones that we discovered were really running on fumes by the time we got this grant round of access to care grant renewals going. This round does go from July 1st through the end of September. And the thinking here is that for those grantees who were awarded as part of a burn, if that funding kicks in sooner, that they would no longer need the access to care grants because they're now part of a burn and are funded separately. For those who aren't funded as part of a burn, behavioral health resource network, that funding would follow them to the end of September. And my understanding is any remaining funds would need to be returned at that point. And we would expect to have no further grant extensions at that point. And I don't think John is on. If he is, he could jump in. Otherwise, that's what I believe at this moment.
Okay, thanks. I was just curious where that, because I was really kind of curious about what type of money that is. Is it the general fund? Is it reserve? Is it ARPA? And does that restriction for the end of September come with that type of funds, or is it just a OHA decision? Or
yeah, Ron, it's an OHA decision. Those are general funds, and it's just our commitment to help ensure that the provider network that you all created through Access to Care still is robust through the end of this period while the burns are being stood up. So there's no arbitrary funding deadline. It's an agency deadline, and our belief is and hope is that the burns are up and running by October 1st. So that's the reason that we put in that deadline.
Thank you very much.
Welcome. All right, next slide, please. So just I want to give a brief overview of the key investments, some of which you have probably heard of, some of which you may not. And then Rusha is going to jump in on the 988 crisis system and want to think a little bit about opportunities for integration with Measure 110. Not a requirement, of course, but looking for opportunities to make interconnections that will help people. And then if there's time and interest, we can have a discussion. Next slide. So some of the things you may have heard of recently that does impact at least a portion of the providers that you all have funded is we've had a severe workforce shortage, and it's not just exclusive to behavioral health, it's across all of healthcare. Our healthcare providers are exhausted. So we've lost a lot of nurses and doctors, other professions in healthcare generally. That's been true for behavioral health, and so House Bill Affordable 4 allowed us to push significant funding out to community behavioral health providers, a wide range, and including size and type, but all that are only those that are certified by OHA. In some cases, there are peer-run organizations that don't have a certificate of need through OHA that were not eligible for funding, and not because it's our choice at OHA. It's because of the way the statute was written. So that's how the eligibility criteria went out. So that funding was required by statute to be out the door by the end of the month, by the end of May, and we were able to meet that deadline. Next slide. The second part that comes right behind that, so shoring up the workforce and then stabilizing workers. And so this has to do with the Medicaid system. So any programs or any individuals who receive Medicaid funding were eligible for this, and we were looking at a substantial increase in Medicaid rates for behavioral health services because those were underfunded for a long time and not on par with each other. Addiction was funded at a lower level than mental health, so this funding was designed in part to shore up addiction and substance use disorder funding. It was also designed to help bring up overall behavioral health rates more on par with primary care. So you'll see a variety of different types of funds that were for increase, but all on average about 30%, which is a very substantial increase in rates, and it's meant to really help organizations stabilize and to help them attract and retain high quality staff. Next slide, please. Here's one that you may have heard of. So as part of Measure 110, you've seen a lot of requests for infrastructure, so housing, treatment programs, that type of thing. There were also two buckets of funding that were substantial in the legislation. One is $130 million going back to 2021 that are meant for infrastructure. There's planning grants, and I want to show you the results of that. You'll have the slide deck. We won't have time to dig into those, but in terms of planning for next steps, you can see from the various communities the type of infrastructure that these communities were really looking for. This 5024, $130 million was really shaped to provide services with a focus on people with severe mental illness and people who would be likely candidates to use the Oregon State Hospital. And so these were not funds that really lent themselves well to connecting or integrating with Measure 110 funds for people who really struggle or need services around drugs and alcohol, although many of the people who go to the state hospital, of course, also use drugs, use alcohol, and so there is those co-occurring challenges that people have. Next slide. Here's an additional $100 million from this past session, 2022. These funds are going directly to counties. And so in some cases, projects that the counties wanted were in part funded using these funds, and in some cases, braiding funds between Measure 110 funds, or at least proposed to do that, and these funds coming down. These were more flexible for use with a broader range of infrastructure, including housing, supported housing, and various types of treatment infrastructure. Next slide. The workforce initiative. So this is separate from the other workforce initiatives that you just saw around rates and incentives for recruitment retention. This was specifically designed in the 21 session to help increase workforce diversity. And unlike prior programs that OHA has run, this one was targeted to a much broader range of types of providers. In the past, many of the program focus has been on primary care, so docs and nurses, with some funds going to behavioral health providers, but always licensed practitioners. Here, it's not restricted to that. So the full range of behavioral health providers are included, and it includes things like loan reimbursement, clinical supervision, but also, interestingly and importantly, things like housing, scholarships, and childcare incentives. Next slide. And you can see the gradual rollout of this initiative and see the dates of these various awards. It started out with loan repayment for folks who have school debt, then housing stipends coming next. In the cycle of awards that's just coming up, also followed by scholarships, and then childcare subsidies and other incentives. Next slide. Included in also in 2021 legislation are peer-run respite centers. There's examples of this from around the country. You see the picture of a peer-run respite coming out of New York. The centers were funded and are still finishing up the rules section, and the funding ought to go out the door, we believe, in early fall, perhaps October. Next slide. And with this, I'll just give a couple opening remarks and then turn it over to Rusha. So 911 is 988 is the 911 for behavioral health, and as Rusha will talk through, it follows some similar strategies. I'll just highlight that I think that there's opportunity for integration with Measure 110 services, in that there's a universal call center, which probably ought to have a bridge at some point with the call-in for Measure 110 services. That would be something that we could build in if Lines for Life continues to be the contractor for Measure 110. They will be the primary initial provider for 988 services, not the only one, but a primary call-in center, and there's an opportunity to integrate services that are provided through the burns to other services that are available in the community in terms of stabilization, crisis support, stabilization centers, and follow-up services. So someone calling into 988, if that's something that you're interested in, authorize, could be referred to the local behavioral health resource network if their challenges met the criteria for that. So again, an opportunity for, as we think about the next round of funding, and to integrate behavioral health resource network services with the rest of the system, want to bring forward opportunities for that integration. And with that, unless there's questions for me, I'll turn it over to you, Rusha.
Thank you, Steve. I don't see any hands, so I'm guessing there are no questions at this point for you. And thank you to this group for inviting me today to present on the work that we have been doing on 988 and the behavioral health crisis system, and because there are some really great ways to coordinate better with the Measure 110 work in this council, and then also some ways to use our resources from both of these efforts more efficiently to address the fact that individuals who touch one part of the behavioral health system, they potentially touch every other parts of that system as well. So I will talk a little bit about the 988 concept and the overarching behavioral health continuum, crisis services continuum. And then I'll talk about where the work is at right now for each of the components within that system. And then finally, a little bit about where are some opportunities that we have identified so far, some of which Steve mentioned, and then also hoping there is continued discussion with this council. So what you see here is a parallel picture of behavioral health crisis to physical health crisis or other kind of crisis that already has a system in place through 911. And a reminder that I always try to bring up is that a lot of us have heard of 988 at this point, but we need to remember that 988 is one of the components of the entire continuum of services for the behavioral health crisis system. And 988, it replaces the current 10-digit phone number for the National Suicide Hotline, but it also expands the scope beyond suicide and risk of self-harm, but also to all kinds of behavioral health services. So you will see here, there is 988, which is the phone number that an individual can call if they think that they themselves or someone around them is in a behavioral health crisis. And then the services that follow are the mobile crisis interventions, and then stabilization services, and then some follow-up services to prevent a future crisis for individuals. Next slide, please. And also thank you to whoever is moving the slides. So this is a very complex picture, but I'm hoping that some of you, or if not all of you, will have some time to really dive into this. But this is really the picture of the future state that we're trying to build. And it really shows how the 988 and behavioral health crisis system fits within the entire crisis system at large within the state. So you will see where there are the connections with 911, and then also in the middle there, you'll see where some of the connections are between EMS services and then mobile crisis services. And then at the very bottom, you will see there are some connections between crisis stabilization services, and if there are things such as crisis walk-in centers, stabilization centers, which I will talk about in a second here. And then what are the relationship with some of the other facility-based stabilization or facility-based service areas, such as hospitals, or if there are community-based facilities where individuals can get services, or if there is emergency department. So how all of these components of the crisis system can work with each other in a way where appropriate response for behavioral health crisis is available instead of a law enforcement response to a behavioral health crisis, or also making sure that certain situations where law enforcement and behavioral health crisis system needs to work together to provide services to individuals, those are also identified accurately and appropriately in a culturally responsive way and a developmentally appropriate way across the state. Next slide, please. So the 988 legislation that was passed by Congress, it was driven a lot by this model for behavioral health crisis services, which is called the Crisis Now model. And it has four main components. One is a place, someone to talk to, which is the 988 call center, where you're able to call anytime you think you need behavioral health services because of a crisis. And then the next one is someone to respond. This is where the mobile crisis teams, which currently exist across the state, but not at the capacity and the standards that we are hoping to get to and working towards. And then the third component is crisis stabilization, which is a place to go. a place to go that is not ED or jail if a person does not need those. A place to go to receive stabilization services for behavioral health needs that focuses on integrating the individual back to the community. And then the last part is follow-up services. So those who do go through that crisis system and that continuum of services within that crisis system, what are some of the follow-up services within the community that they are able to get connected to so that we are helping them prevent a future crisis. Next slide, please. So in 2021, legislation House Bill 2417 was passed. It was a few months after the 988 legislation in Congress was passed, and across the country, multiple states, over 30 states have passed some kind of legislation around 988 and this crisis now model. And House Bill 2417, and a lot of you may already know this, really directed OHA to implement this enhanced behavioral health crisis service system. It appropriated some funding for the 988 call centers. So only those organizations who are accredited by the National Suicide Hotline are the ones who can serve as 988 call centers. So far, we have only 2 in Oregon. One is Lines for Life that serves the entire state. And there is Northwest Human Services that serves Marion and Polk County. So these are the 2 988 call centers we have so far in the state of Oregon. And also House Bill 2417 appropriated some funds to expand and enhance mobile crisis services and really to align with the ARPA provisions for mobile crisis services. And I will come back to that in a second. And then the last piece is crisis stabilization services, including crisis stabilization centers. This was the part of the legislation that had directive for OHA to identify rules and a plan to implement and establish the crisis stabilization centers. However, there was no funding appropriated for these crisis stabilization centers. Next slide, please. So as we have been doing this work to implement House Bill 2417, and even before that, when 988 as a federal law was passed, there was a governor's work group which had worked a lot in identifying what could look like a crisis now model in the state of Oregon, but also customized to the needs of state of Oregon and the communities who are here. So following the 988 governor's work group, and then it was dissolved at the end of 2021, we established the Crisis System Advisory Work Group, which is in short called the CSAW, and that group is 100% individuals and families with lived experiences. And it's not a public work group. However, it is facilitated, the conversations are facilitated by OHA staff, and we really try to follow a more town hall manner where we really try to identify from the communities how they would want to experience behavioral health crisis services in their community. And they drive and guide a lot of the policy decisions, including rules and contracts and other kinds of statutory changes that we may or may not need. They really drive those policy decisions for OHA. So truly a community-led process to make sure that we are developing and designing a system that is serving the community in a culturally responsive way and a developmentally appropriate way, and also in a linguistically appropriate way. So also we recently just finished the recruitment, application and recruitment for the CISA steering committee, which will be a public meeting. And me coming here today was very timely because we just got the web page for the CISA steering committee, and I will be happy to share it with this group as well. But the first meeting for the CISA steering committee is next week on June 29th, and that will be a public meeting, and it will follow very much the same kind of protocol that this council follows. There will be a YouTube link available. Everyone is welcome to observe. And we have a very robust group that we have recruited, and they are really excited to do the work. The CISA steering committee, their purpose is more to take the recommendations that's coming from the crisis system advisory work group and really identify if there are any further gaps in those recommendations, and then formally move those forward to OHA. The reason we have these two separate meetings, because the regular crisis system advisory work group, they were not in favor of having a public meeting. The group really wanted to keep that conversation in a safe space because individuals share a lot of their own experiences with the crisis system. However, the CISA steering committee will be a public meeting, and you will be able to, anyone will be able to observe the discussions around the recommendations coming from both groups in there. Next slide, please. Some of the other work groups that we have established to work with our other community partners and providers who are an integral part of the behavioral health crisis system are the Association of CMHPs, who time to time works closely with the crisis system advisory work group as well to gather recommendations or have some open dialogues around where there are some expectations from the community, but also how to make sure that mobile crisis teams and the staff who serve in those teams are feeling safe as they serve their community in various kind of crisis situations. The other partners we have been working with very closely are the coordinated care organizations, since they are also responsible for delivering, making sure that mobile crisis services are available in their regions. And the third work group that we have established is a work group where there is representation from each 911 program representation and a 911 program region. And that work group is really working on creating a roadmap for 911 programs across Oregon so that they are able to establish some standardized coordination within their region with the 988 call centers. Next slide, please. So as I was talking about the future state of the crisis system, so another thing to remember is that even though 988 as the phone number goes live on July 16th nationwide, and what that really means is that instead of having to call the 10-digit National Suicide Hotline number, anyone should be able to call 988 and reach that same phone number. So even though that phone number switches to 988 on July 16th, it's really the first step into the transformation of this entire system. To transform this entire system, we still have a lot of work to do, and there are some things that we are immediately putting in place in the system to make sure that even during the transitional area, we are making the services that are needed in the community available. And then how can we keep improving on them to truly reach that crisis now model in the future. So some of the things that we're doing right now is we are providing funding to our 2988 call centers to hire and train workforce and build capacity so that in anticipation of increase in call volumes, those call centers are able to answer all the calls that come to them. There is a standard for 988 call centers, which is the 90/20. And what that really means is that the 988 call centers should be able to answer 90% of the calls in state in no more than 20 seconds time of answer rate. Just like 911, with 988 as well, if a call is not going through the in-state 988 call center, it gets kicked to the national backup. However, we want to make sure that there is enough capacity to answer at least 90% of those calls in state, and in subsequent years, increase that threshold to 95%. So that's something we're immediately putting in place. And the other effort and investment that we're doing right now is using the funds appropriated by House Bill 2417. We have released $10 million to our community mental health programs to hire and fill in any gaps in the infrastructure and workforce for their mobile crisis teams. In fall of 2022, we will be releasing another $11 million to our community mental health programs. And the release of that fund is contingent on OHA's approval of their plans that how within each county they will reach that crisis now model and really reach the goal of the enhanced mobile crisis service and mobile crisis teams. And something that's coming along in the later part of this year, and then more work to be done along with our legislative partners in 2023, is identifying how to establish that network of crisis receiving centers or crisis stabilization centers across the state, because that's one part of the crisis now model that we don't have any kind of robust infrastructure to build off of at this point. Next slide, please. So some of the things that, like I mentioned, there are some things that we have identified where we can start a deeper coordination with Measure 110 and then this council. So one is a state plan amendment, which is where we are pursuing a higher federal match for mobile crisis services from Center for Medicare and Medicaid. And that has been submitted on June 14th, and we are awaiting approval from CMS. What that really means is that for mobile crisis services, the state is able to get a higher match for those services delivered, which in turn helps us establish higher rates for our providers. We, on our 988 webpage, which I will provide the link for, we also have the 2 988 call center contract drafts up for public comment. I would really encourage all of you here to go take a look at those to really understand what is the expectation from these 988 call centers when it comes to providing crisis services to individuals over the phone. And the final piece is participation from this council in our rules advisory committee for the new mobile crisis rules. I believe the OAC, this Measure 110 OAC was part of the invites that had gone out. We had initially tried to recruit for recruit RAC members for those rule committees. However, we were not at the diversity that we were expecting, and also we should have under statutory requirement. So we have postponed the dates to July 12 to 15 for the RAC process for the new mobile crisis rules. However, the draft rules text was sent to everyone who was invited to the RAC. So we are happy to send that again, but somewhere in your emails, you will find those draft rules. And I, again, encourage everyone to take a look at those because there is a lot of enhancement and improvement to our mobile crisis services, including making it easier and reducing the number of assessments that happen before an individual receives mobile crisis services in person when they need it or when they request it. And I believe that's the last of my slide. And I apologize, that was a lot of information. I'm happy to bring more information or focus on certain things that I talked about today, but also hoping that there is, that we work together to identify more areas to coordinate with Measure 110 and the council here.
Thank you, Usha.
Go ahead, Steve.
Could take the slides down, please. Go ahead, Blue, sorry.
Oh, you're good. I just wanted to check and see if anybody had any questions. I just had a brief question, which I'm just curious about the ways that 988 will be promoted or communicated to both service providers and the general public once it is available as an option.
Usha, you want to take?
Sure, that's a great question. At this year, we are really working on building that media campaign and the really culturally appropriate, and again, like I mentioned, linguistically and developmentally appropriate media campaign and promotional plan, because we are still working on developing some of the parts of the system and funding with startup funds some of the services within the system. We are doing more of a soft launch at this point, where you will see some communications through newsletters and other areas, but there is not a plan for any billboards at this point. But we are working with our community partners and providers, all of whom one way or the other either are impacted by the behavioral health crisis system or come in contact with the behavioral health crisis system to make sure that they are aware of the efforts that are going on.
Thank you. Okay, so I'm gonna double check, but I think that is everything we have on the agenda for today, but I want to just circle back with Jessica and make sure that that's all we've got. Looks like that is accurate. Oh, Henry, you have a hand up. Go ahead.
Yeah, I don't want to belabor the point. I think that we've just been inundated with a lot of information, and I know that the council probably wants to get going on their day. So I'll try to make this brief, even though that's difficult for me. I would just appreciate the work that the folks in the legislature are doing, and the OHA and all the community, the folks that have an interest in the community regarding crisis services. I also think that supporting crisis services isn't going to address the larger problem of lack of affordable healthcare in Oregon and in the country. I think that's partly why we have folks accessing crisis services, is because they're not seeing their normal providers on a regular basis and getting the routine care that they need in order to avoid crisis. So I don't think that's anything that we as a committee can address either, or even the OHA in that regard. I do also have some questions about what we can do as a committee or a council to help support these services. It also seems like when we are providing dollars to community health organizations, like the behavioral health centers in rural areas, that those areas are also providing crisis services, so that naturally will kind of dovetail into the services that we're supporting. And then just the idea of, I don't know, I maybe have missed it, that crisis, centers there's not an allocation for dollars for crisis centers. And I think that having been in the emergency room, sitting with folks who are experiencing acute psychosis and suicidality due to their ingestion of substances, I can say that, again, Oregon drastically lacks in its ability to support those services for those folks. And that actually then impacts worker morale and retention. So just all those things to note. Thank you for your presentation, and I hope that was brief. Thank you.
Thanks, Henry. Okay, so I think we're, no, go, anything else? Okay. Well, then I guess that is it for today, and we will see you next Wednesday. I'm pretty sure we will have some more things to vote on, so please try to